Let me now introduce John Alexander, Associate Professor of Cardiovascular Medicine at Duke University, who will talk about the latest developments in the management of ACS from hospital care to long-term follow-up. John, welcome.
Thank you, Kristin, and thank you for inviting me. It's a real pleasure to be here. First of all, again, let me apologize for I caught a cold on a plane a couple days ago, and so my voice is a little shaky, but I hope you guys can all hear me. And I feel better than I sound, so don't worry. So Kristin asked me to talk on this topic, and I thought a lot about it, and I'm going to try to be a little bit provocative in my comments and hopefully generate some discussion. So just by way of disclosures, which are also publicly available on this website. So these were data that Tracy already alluded to from the landmark CURE trial conducted in the early 2000 period, looking at clopidogrel plus aspirin versus aspirin alone in patients with non-ST elevation acute coronary syndromes. And there's a very impressive 20% relative risk reduction. But what most people don't talk about is that there's about 80% of patients who are still having events, and that we haven't, the addition of clopidogrel to aspirin certainly hasn't eliminated the problem of recurrent ischemic events. And the other thing that I think is important to note is that almost all of these events, if you think about the average length of stay for an ACS patient, happen after hospital discharge. And so most of the data that Tracy showed you, most of the data that's available in the care of patients with acute coronary syndromes to date, and most of our guidelines really focus on hospital-based early management of acute coronary syndromes. And there's been much less focus and much less focus in the whole quality movement and in our healthcare system and infrastructure on the outpatient setting. And I think our real gains in the future are going to be in outpatient management post-ACS of these patients to hopefully help prevent them from having recurrent events. So I reviewed, in preparation for this talk, I went over the ACC-AHA 2007 non-ST elevation acute coronary syndrome guidelines. And there's 157 pages. Actually, the executive summary is 75 pages. And there's a total of 298 recommendations in the guidelines. There's 187 or 63% roughly that are Class 1 recommendations, about 28% that are Class 2 recommendations, and about 10% that are Class 3 recommendations. And I'll go over in a minute what these are.
You have those all memorized and tucked away. And
that's right. So that's a lot. And then in preparing this talk, I got out the slide set that comes with these guidelines, 247 slides, and you only gave me 30 minutes. And so I honed it.
Hopefully you took out about 200.
Anthony keeps complaining because I kept giving him new slide decks. But there are actually 62 slides on secondary prevention. And for those of you who don't only take care of cardiology or even don't only take care of acute coronary syndrome patients, there's also the acute MI guidelines, the AFib guidelines, the heart failure guidelines, the valve guidelines, etc. So our guidelines, I think, are getting overwhelming if one wants to follow all of the recommendations that are in them. These are an overview of the organization of the guidelines. Class 1 recommendations are really things that should be done. And so the fact that there's so many of them is a problem if we're all supposed to be, in my view, if we're all supposed to be doing all of them in the vast majority of our patients. Class 2 are reasonable or maybe considered, and Class 3 are things that shouldn't be done. The other important piece of information here, though, is these levels of evidence, level of evidence A, B, and C. And I want to just highlight here, level of evidence B means data from one randomized trial or observational analyses. And we've all talked and have experience with some of the challenges of interpreting observational analyses. And then level of evidence C is my favorite because it's expert opinion. But it's expert opinion without data from randomized trials or observational studies. Otherwise, it would be level of evidence A or B. And so it's really just opinion in my view. So our colleague Pierluigi Tricocci published this great paper in JAMA last year looking at the non-ST elevation acute coronary syndrome and the acute MI guidelines that came out in 2007 and the distribution of the classes of recommendations and the evidence. And indeed, there's been an accumulation of level of evidence B and C recommendations in our guidelines, I think representing that they're getting more complicated without necessarily really improving our ability to take good care of our patients. So I really think there are two secrets to high-quality post-ACS care. And the first one is to simplify it. At least that's what I do, and that's what I really think one has to do if you want to take care of patients. And then the second, which I think is also critically important, regardless of whether you simplify it or not, is to develop systems of care. And we practice, Kristin, in a unique environment in a large academic medical center at Duke with its own challenges. But every healthcare delivery system is different, and the ideal system of care is different probably in each of those environments. So this is, this 3x5 card here is really the system of care that I use. And actually, you guys can't see it, but it'll develop during my talk. Really, if you do what's on the front and back of this, you'll really get about 85-90% of the evidence-based medicine into our patients in the post-ACS setting.
And you have handouts of that for all of us?
Yeah, I can actually help people. After this talk, people will be able to make their own card without much difficulty. So these are really what I see as the key elements of quality post-ACS care. There are really 5 drugs that virtually all patients who are post-acute coronary syndrome should be on. Those are aspirin, clopidogrel, a beta blocker, an ACE inhibitor, and a statin, or HMG-CoA reductase inhibitor. And I'll develop a little bit of more detail about these. But I'll also point out where I don't really think a lot more detail is truly evidence-based. There's a couple lifestyle things which are really critically important, I think, in our patients, and where there's good evidence that physician and other healthcare provider intervention can make a difference. And those are smoking cessation, recommending exercise, and discussing with our patients dietary approaches to care. There are a couple diagnostic tests that are important and important for us as providers and our patients to think about. And those are an assessment of the left ventricular ejection fraction, patient's blood pressure, their lipid profile, and whether or not they're diabetics. And I know I won't talk a whole lot about lipids and diabetes because Mike Blazing and Darren McGuire are both here, and we'll be talking about those later. And then really I think a key part of our improving the care of patients, and particularly this issue of transitions of care from the inpatient to the outpatient setting, is education, communication, and follow-up. And that includes patients of families and of other care providers, because most of us don't take care of our patients alone. Okay, so on the front of this card, there are really 5 drugs, and they're the same 5 drugs I listed before. I did add or angiotensin receptor blocker because there is some evidence for angiotensin receptor blockers in this population as well. And then for each of these, I'm going to develop this a little bit and talk about for which patients or who, which agents, what dose, what durations. And one thing that I think as we've gotten into the inpatient quality movement, a key element is who not to prescribe these medicines in, who has contraindications, and how important it is to document those, how important it is for us to know why we're not giving somebody aspirin, or know why we're not giving somebody clopidogrel, or beta blocker, or ACE inhibitor statin. There are, of course, valid reasons. So you're all familiar probably with this figure, which at least this edition of was first developed by our colleague Rob Califf, looking at the development of information on how we care for patients in a quality setting from early science through clinical trials to clinical practice guidelines to performance measures and to outcomes. And I'm going to sort of walk through each of these agents along this cycle. First, I'm going to start with clinical trials and the clinical practice guidelines piece. So this is probably the most famous and best overview of aspirin. I did include aspirin in my
I
comments.
want to see somebody speak to aspirin.
It's really, I think, the foundation of our care of patients following acute coronary syndromes. And this is the Antithrombotic Trialist Collaborative Meta-Analysis, which is really an overview of aspirin versus no aspirin in patients with a broad spectrum of vascular disorders, including prior myocardial infarction, prior stroke, and other high-risk populations. And in really all of these, there's a roughly 15-20% benefit in the reduction of recurrent vascular events with aspirin. Most of these, now we'll talk about aspirin dose a little bit, most of these were done with 325 of milligrams a day of aspirin, although the data doesn't seem to be very different in the cohort that have 200 or 81 milligrams a day. Those are not randomized comparisons, however. And so really my summary of the ACC-AHA guidelines are that everybody following an acute coronary syndrome should be on aspirin indefinitely, and that has a class 1A recommendation. So from our standpoint with cardiovascular disease, really everybody with coronary disease, post-ACS, post-ACI, should be on aspirin indefinitely. As Tracy already alluded to, there's not great data on what dose is best. There's observational data that shows that higher doses result in more bleeding. The stent clinical trials all used 325 milligrams a day of aspirin, so that's what's in their labels, but it wasn't compared to anything, so we don't know if it's the right dose. So I really think that a dose anywhere in there is probably adequate, and what's much more important is that the patient be on aspirin and actually take it. The duration's indefinite, and I think that's an important thing to talk to patients about. And then the reasons not to prescribe aspirin are really very few, and that is a well-documented aspirin allergy. And I have lots of patients who say I'm intolerant to aspirin, and that's a great educational opportunity to talk about risks and benefits.
How frequent is aspirin allergy, true aspirin allergy?
Yeah, so there's not great data on this. The best data comes from the large pharmacy registries that look at, and if you say that true aspirin allergies are the bronchospastic hives, reactions, yeah. It's less than 1%. It's about 0.5% of patients who have it. And it seems to be, if you have it, you have it. You don't develop it over time.
So not a lot of reason not to give an aspirin.
No, and certainly not acutely, and also I would say not chronically. This again is the results of the CURE trial, which we've already alluded to, a 20% relative reduction in death, MI, or cardiovascular death, MI, or stroke, in mostly an ex-US 2000 era study. Highly statistically significant. However, as Tracy alluded to, as with all effective antithrombotics, including aspirin, clopidogrel increases your risk of bleeding by roughly 25-30% when used on top of aspirin. So again, my summary of what's in the guidelines is clopidogrel really has a class 1A recommendation, and if you read the guidelines, they say for ACS patients, 1 month to to at least 1 year. They don't say not to continue it longer because there's really no evidence not to continue it longer. It's just that the duration of follow-up of the randomized trials ended at roughly a year. However, the curves can appear to be continuing to diverge slowly. And so clopidogrel really, in this population, the post-ACS population, should really be used in everybody, both those who are treated with PCI and those not. The long-term dose is 75 milligrams a day. Tracy showed the data from OASIS 7, current OASIS 7, that used a higher dose for a week, but that's a short period. If you think about the long-term accrual of events, really everybody should be on 75 milligrams a day. And the duration, as I alluded to, is really to at least 12 months in patients with ACS, bare metal stents, or drug-eluting stents. And so I generally keep my patients on clopidogrel until they have a reason to come off of it. That could be cost, that could be bleeding, or in a small set of patients, an excessive risk of bleeding. However, I've always found that challenging because the patients at high risk of bleeding are also always inevitably the patients at high risk for recurrent ischemic events. Tracy also already showed the Triton TIMI-38 data with prasugrel, which enrolled a patient population post-ACS undergoing percutaneous intervention, and there was a substantial clinically relevant improvement in ischemic events with prasugrel versus clopidogrel that was mostly early, but also very importantly included later events and included, importantly, a reduction in stent thrombosis. However, it does come with an increased risk of bleeding, including an increased risk of serious and fatal bleeding. So I use prasugrel, I think, in a fashion similar to how Tracy does, in patients who are at high risk of stent thrombosis and who are at low risk of bleeding. And again, there's this challenge that those are often not the same populations of patients. And then another really interesting thing, I think, about how prasugrel is being utilized in the clinical setting is this risk of bleeding really continued out over the long term of follow-up. And so some people are using the approach of keeping people on prasugrel for a relatively short period of time and then transitioning them to clopidogrel without really good evidence to do so. Just briefly, I wanted to throw in some data on beta blockers post-ACS. There's not a lot of data actually in patients with non-ST elevation acute coronary syndromes or unstable angina for the use of beta blockers. But since they have a class 1 recommendation in the guidelines, I thought I'd put it in, and it's on my card.
And that's largely data out of STEMI. So.
That's correct. It's mostly data out of STEMI and with left ventricular dysfunction,
right,
which most patients with ST elevation myocardial infarction have. So this is a modest-sized, couple thousand patient clinical trial, again from the early 2000 decade, looking at carvedilol versus placebo in patients with ST elevation MI and LV dysfunction without clinical heart failure. And there was an important mortality reduction over several years of follow-up. So patients in the guidelines have post non-ST elevation acute coronary syndromes, and they really include everybody. And I'll talk about this a little bit more, get a 1B recommendation, a little bit longer, less strength of evidence. But again, continued indefinitely, those curves were certainly continuing to diverge. So I use beta blockers in those patients who have an MI, LV dysfunction, or who have a lot of ventricular or atrial arrhythmias. The agent here, now we're going to need to talk about agents. And this is another key point in my Keep It Simple. I really encourage the fellows and trainees that I work with to pick a couple beta blockers. There's a bunch out there that have pretty good evidence, and I really generally use short-acting metoprolol in the hospital and generally long-acting metoprolol or carvedilol outside the hospital in the long-term secondary prevention setting. There are some other beta blockers that also have data in this population, though. Now, dose. This is the other important thing. That the dose that we know is beneficial is the dose that was used in the clinical trials. And that's actually usually a pretty high dose. And so here we should be titrating. You shouldn't feel good just because a patient's on a beta blocker. You actually have to try to get them to pretty high doses of the beta blockers, provided they tolerate it, provided they don't have symptomatic hypotension or other symptoms that limit dose titration. And here's the other thing that I'll bring in, which is actually on the back of the card, which is blood pressure. So we also, beta blockers are one of the 2 antihypertensive medications on the card. And really getting our patients educated to knowing what their blood pressure is. And I've recently been amazed that most patients don't know what their blood pressure should be, which is also a critically important piece of education. And really our goal of getting people's pressures down to less than 130/80 is another thing we can use beta blockers for. As I alluded to, duration is indefinite, and the reasons not to prescribe symptomatic hypotension, clinically relevant bradycardia, or well-documented bronchospastic response to beta blockers.
And this doesn't mean just somebody who has COPD or maybe has asthma.
No. One should definitely give them a trial of beta blockers. Many patients tolerate it fine. And also lots of patients who think they have asthma don't have asthma. They either have heart failure or which beta blockers might be quite effective at treating. All right. The 4th medication on the front of my card is ACE inhibitors. And this is a landmark study, a really amazing study looking at, called the HOPE trial, that looked at ramipril up to 10 milligrams a day versus placebo in a post-ACS, in a coronary artery disease population, or about a third of the population just had diabetes. Right. And here, ramipril had a substantial effect on cardiovascular death, myocardial infarction, or stroke, about 22% relative risk reduction that was highly statistically significant. So here, our guidelines have ACE inhibitors if there's heart failure, LV dysfunction, diabetes, or hypertension. They don't mention just coronary artery disease as a Class 1A indication, which I think is a not entirely accurate interpretation of the literature. Now, fortunately, almost all my patients with coronary disease have hypertension or diabetes or LV dysfunction or heart failure, so they'd all end up on an ACE inhibitor anyway. So here again, it's important to talk about agents, and I make the same comment. It's likely a class effect for ACE inhibitors, but I tend to use ramipril or lisinopril as my long-acting outpatient ACE inhibitors. Ramipril in people with normal left ventricular function because it has great data from the HOPE trial, and lisinopril in people with LV dysfunction because it has great data and it's generic, which has important cost implications. Dose, same issue as with beta blockers. We really need to be titrating these drugs to the doses that they were effective at in the clinical trials. People need to be on them indefinitely. And again, there's a limited list of reasons not to prescribe them. One thing that I think is really important is renal insufficiency. People are hesitant to start ACE inhibitors in patients with renal insufficiency. However, there's pretty good evidence that they're renal protective, and that's probably a particularly important population to start them in, particularly because that population is also generally undertreated and at high risk for recurrent events. All right, and then finally statins, and I picked here one of many highly positive trials, this one comparing two statins, looking at a high dose of atorvastatin, 80 milligrams a day, versus a low or moderate dose of pravastatin, a less potent statin, 40 milligrams a day in a post-ACS population. And here you can see a highly statistically significant 16% relative risk reduction in recurrent events. And if you compare statins to placebo, they have mortality benefits, and we've gradually been broadening the population. It's now really anybody who has coronary disease or diabetes, and I won't talk about the primary prevention data. Mike Blazing might, but you asked me to talk about post-ACS. And really here again, there's about 5 approved statin drugs. I generally tend to start with atorvastatin or simvastatin because I think they have the best evidence supporting their use post-ACS, and simvastatin is now generic. Again, it needs to be titrated to the dose used in clinical trials and to get the LDL cholesterol to less than 70. So this, I think, is a really important message. Our lipid-lowering guidelines all really focus on target LDL, and I don't think that's supported by the evidence. I mean, really, the clinical trials randomize people to doses of statin, and I think that the evidence supports the idea that a lower LDL is really always better if it's achieved with a statin. And I recently had this conversation with my father, who has coronary disease, had bypass surgery, is in his 80s, and his LDL is 60-something off of a statin. And so I finally convinced him and his cardiologist to put him on 40 milligrams a day of simvastatin. Duration here, again, is indefinite, and the reasons not to prescribe are well-documented allergies, although people who have experience with lipid lowering, often you can get people on really low doses of alternative agents if they're not tolerant to the doses that were used in the trial of atorvastatin or simvastatin. All right, so then there's the back of the card, which really has 2 sets of things on it. The first is lifestyle, smoking cessation, exercise, and diet. And the second is a bunch of assessments that I alluded to, looking at left ventricular function, particularly to determine whether these patients might benefit from an implantable defibrillator, blood pressure, lipid lowering, and whether or not somebody has diabetes, and maybe how well it's managed. So the guidelines have Class B recommendations really for all of these, reflecting a less strong evidence, but they're all Class 1 recommendations. And I'd like to remember this by B. B is on the back of the card. So you can remember this. But the most effective intervention at getting people to stop smoking is having a healthcare provider recommend that they stop smoking. And so I spend time with my patients, both in the inpatient and outpatient setting, talking to them about smoking cessation. It actually is a cost savings for the patient, and they can invest that money in some of the medicines on the front of the card. Weight management is important, although I think less important generally than physical activity and diet. And I spend a lot of my time talking to patients about the importance of physical activity and the importance of a reasonable diet. I just want to make two comments about these quickly. Physical activity, I think most patients struggle with it because they try to achieve a high level of physical activity at the beginning. And everybody feels worse after they exercise for the first month that they exercise. And so I always suggest to my patients that they really try to exercise every day and that they start with very small amounts of exercise. I had a patient in clinic about a month ago who finally is now exercising about an hour a day. She started about 4 years ago putting on exercise clothes for 15 minutes a day and doing no exercise. And we did that for a couple months. And now she's in good shape. So, and then diet. The habit with exercise is more important than the exercise. And you'll never get someone to start exercising if you tell them they have to do an hour a day. And then diet is also something I love. My patients ask me, and I'm not an expert in healthy diets, so my patients ask me, what should I eat? And I'm like, well, why don't you tell me everything you eat that's bad for you? And they rattle off a list of all the things, all the carbohydrates, all the high-fat food, all the fried food. And so generally I tell people, don't eat what you know is bad for you, and don't eat out more than once a week, because restaurants make food taste good with salt and butter. And so with those two things, I think patients can get on a pretty good diet. All right, so with that being said, that's really the evidence that's behind these interventions on my card and the guidelines about them. But as Bill Gates said here up at a school up north, humanity's greatest advances are not in its discoveries, but in how those discoveries are applied. And I think and I'm heavily involved with a whole host of new drugs that are being developed that are really very exciting in the post-ACS setting. But I think our biggest potential to impact our patients is in using some really basic drugs better, really basic drugs and other interventions more effectively. So I want to talk just a second about that.
Good. I was going to say, so you've told us everything that needs to be done and what we can do, but how do we get patients to do what we need them to do?
Yeah, so I'll come to that. So these are data, again, from the ACTION Registry looking at our use, and this is at discharge, and Tracy already showed some of this, our discharge use of aspirin, clopidogrel, beta blockers, ACE inhibitors, and statins. And they're all high. They're all basically over 80%. But I'm not sure that's so good. I mean, there's 500,000 of these patients, or actually there's more than that. There's roughly 1 million of these patients a year in the United States. So those, 5-10% are large numbers of patients who are being deprived highly effective therapies. And this is at hospital discharge. I mean, this is early when they're in our healthcare environment. McDonald's does much better than this from personal experience. McDonald's does much better than this with ketchup.
Maybe we need to incorporate pharmacies and McDonald's together.
You have a good point. So, and then these are the lifestyle recommendations: exercise counseling, dietary modification, cardiac rehab referrals, really quite low, and smoking cessation, not too bad. And again, this is at hospital discharge. So now there's this whole movement, again, mostly currently focused in the acute setting, collecting our metrics so we can measure how we do. And the Crusade and now ACTION registries will provide these on a hospital setting, hospital by hospital basis to centers, so you can see how you're doing. And that data, I think, is really important. Tracy showed this as well. Our clopidogrel use, for example, is much higher in patients who get PCI, despite the fact that we have good evidence in the medically managed and surgically managed coronary disease patients. And then Eric Peterson showed this very interesting, observational analysis that institutions that do better at achieving these at hospital discharge, their patients have better outcomes. Now, whether this is cause and effect, is not entirely clear, but at least there's a consistent effect that if your hospital does better at achieving quality measures, the patients at those hospitals also do better. Now, Kristin, you've published a lot on hospital length of stay, and it's gone down about a day every 3 years over the last couple of decades following acute MI and non-ST elevation ACS. These are the most recent data from ACTION, where the overall median length of stay is 3 days, but there's a lower quartile of 2 days and an upper quartile of 6 days. And it's a little shorter, actually, for STEMI than the little bit more complicated, more comorbidity non-STEMI. But this is a relatively short opportunity to educate patients prior to their release into the outpatient setting. We at Duke, and you were heavily involved in developing this, have developed a standardized form that really lists all of these medicines on it. So you have to either say that the patient's on it or why they're not on it on every patient that's being discharged. And this is one of the process of care examples that we've developed at Duke, which is really quite effective, I think, at the time of hospital discharge of trying to make sure that at least you're thinking about all of these on my card. The back of this form, which we give to patients, actually has information about the patient's weight, their body mass index, their blood pressure, their lipid profile, and what the goals are, and some rationale behind it. So it's a useful educational tool to begin the discussion with patients. So at hospital discharge, really the key is education about diseases that the patient has, whether that's coronary disease, heart failure, hypertension, diabetes, hyperlipidemia, education about the drugs they need to be on, and many of our patients are discharged on a dozen meds, but I go over these 5 with them. I mean, I sit down and say, you're going to be on these 5, and here's why, and here's how long you should plan on being on them. We talk about lifestyle. We talk about some factors they need to be monitoring, their weight, their blood pressure, whether they have recurrent symptoms, and we talk about plans for follow-up and give them a contact person. So if they have an issue on day 2 after hospital discharge, they'll know who to call. Another thing that's just being, I think, developed in the post-ACS space and that the heart failure community is really much better at is early follow-up following hospital discharge. And here, again, that can be by telephone, which I think, again, the heart failure community has done a really great job with, and relatively early clinic follow-up. Again, important opportunities for education about diseases, drugs, lifestyle, again, lessons from heart failure, and again about the important roles of nurse practitioners and physician's assistants in providing a lot of this follow-up by telephone and potentially clinic follow-up to reinforce the lessons that were learned during that and the education that happened during that 2-day or 3-day hospitalization where there was so much going on. And I put in here a slide of a figure of a pill box. Actually, pill boxes are one of the few interventions that have ever been shown to increase adherence, actually to both active drug and placebo. I really recommend that my patients, particularly those who are on more than these 5 medicines, get a pill box to help organize their medicines. So we've started to look at the outpatient setting. We have nowhere near as much registry data in the outpatient setting as we do in the inpatient setting. At Duke, we have the Duke Data Bank, and you did this analysis now almost a decade ago, looking at our use of evidence-based therapies post-acute coronary syndromes. And this excludes patients who had contraindications to those medicines. And you actually have the trials on this slide, which I liked a lot. But you can see they're all going up, which is good with better evidence. But again, this is something that institutions, sites, practices need to be monitoring and figuring out ways to improve getting all of these really up near 100% in this population. And as part of the Crusade registry, there was a small study done called Crusade Maintain, which looked at longer-term follow-up. Most of Crusade in action are short-term and in-hospital. And this was a cohort of about 1,000 patients enrolled in Crusade that looked at evidence-based medicine use at discharge and hospital and at 3 months. And I think the disappointing thing here is that they all go down. I mean, we're losing ground in evidence-based medicine from when we send somebody home from the hospital till 3 months, not improving on our evidence-based medicine.
Now, did Maintain track why
they did
discontinuations?
They did in some cohorts, and for some of these medicines, it's very complicated. The two big things they looked at, and it was actually about evenly split, was whether a physician or healthcare provider stopped their medicine or whether the patient decided to stop it on their own. And it was about 50-50 between those two things. And then this is using another marker, LDL goal attainment at 12 months. Here, this is in a very small cohort of this population, only 300 patients who had all this data. But only in about 70% of our patients are we hitting the target of less than 100. And really, we have good evidence of the more aggressive goal of less than 70, and we're only getting there in about 30% of our patients. So we clearly have a long way to go using the therapies that we have available today. Sorry. And this is what happened after hospital discharge. 75% of patients who went home on a statin had no change in their statin therapy out to 12 months. 15% started a statin where they hadn't, 10% changed intensity, and 10% stopped the statin. So we clearly, again, have room for intervention in the early and 1 year follow-up period following acute coronary syndromes. So there's now, as you know, an increased focus on outpatient post-ACS quality indicators. And these are some of the ones we're following at Duke. Rates of rehospitalization post-MI, which is something that soon will be publicly reported for institutions. And then outpatient use of antiplatelet therapy, of achieving blood pressures of less than 130/80, of achieving LDLs less than 100, and of using ACE inhibitors if there's LV dysfunction or diabetes. And we collect these on now in our practice on every patient who comes in for a follow-up visit. So almost in conclusion, I have one more section after this, but in conclusion, there's really increasing recognition of the importance of quality outpatient secondary prevention. And I think our biggest potential gains in the long-term prevention of secondary events in this population is in the outpatient setting. Really, I think the key is to simplify and simplify and simplify, because the number of recommendations that are in our guidelines are just overwhelming. And when I'm faced with trying to make sure I do all of that, I think it increases my chances of not putting somebody on aspirin. And so I really focus on these 5 medicines: aspirin, clopidogrel, beta blocker, ACE inhibitor, and statin, on smoking cessation, exercise, and diet, and assessing LVEF, blood pressure, lipids, and diabetes in all my patients. And then it's really, really critical to develop systems to ensure quality. We're all human, we all forget things, and with the amount of stuff that physicians and other healthcare providers are bombarded with, without these systems, there's just no way that we're going to practice high-quality evidence-based medicine. And then we need to further empower our patients and their families in this achieving high-quality care, and that requires education and communication. And through early follow-up contact with patients, providers, and other family members, hopefully we can achieve this. I just have one other area that I want to touch on, and that is the future. I think the post-ACS area is one of the richest areas of drug development, and there's this card. I'm either going to have to get a bigger 3x5 card or cross something off.
Or simplify.
Or maybe cross something off, which is what I'm hoping for, or I have a little bit more room. But there's a lot more to come. So Tracy already showed results of the Plato study looking at reversible P2Y12 receptor antagonist, ticagrelor versus clopidogrel, and again it showed an important reduction in recurrent events, albeit with an increase in bleeding. And there isn't an increase in overall bleeding, but if you look at the non-surgical population, there's an increase in bleeding with ticagrelor compared to placebo, which is actually reassuring to me because all effective antithrombotics increase bleeding, and ticagrelor is no different. This is just a slide I wanted to throw in on warfarin. Warfarin is a drug that we don't really use in the post-ACS setting, but before we had potent antiplatelet therapy, and particularly in Europe, there was a lot of interest in using warfarin post-acute coronary syndrome, and particularly post-ST elevation MI. And the data are actually pretty compelling that if you achieve an INR of between 2 and 3 with what we consider therapeutic dose warfarin, you will reduce recurrent ischemic events, death, MI, and stroke. The problem is really twofold. One is it comes with an increased risk of bleeding, and two is our outpatient healthcare system in this country is generally not good enough to manage warfarin in the millions of patients who are out there post-acute coronary syndrome. This is just a slide of antithrombotics drugs, both antiplatelet drugs and anticoagulants that are either approved for use in acute coronary syndromes or atrial fibrillation or are in development. And the ones on the bottom on both sides are drugs that are now approved, and the ones on the top are drugs that are in development. So there's at least 3 new antiplatelet drugs, 2 of which are oral, and TRA drug being developed that Tracy alluded to is being studied on top of aspirin and clopidogrel, so it may be in addition. There's oral factor 10 inhibitors, several of them being developed in atrial fibrillation, and 2 of them, apixaban and rivaroxaban, as additions to aspirin or aspirin and clopidogrel post-acute coronary syndromes. So there's a lot more to come. And finally, in the non-antithrombotic area space, there are other novel, what I sort of call anti-inflammatory drugs being developed. Here I use daraplidid from the stability trial. It's an LPPLA2 inhibitor, which I don't really understand what it does, but it's being studied in a large, you probably do, Kristin, but it's being studied in a large outcome trial and would be another addition, presumably without an increased risk of bleeding following acute coronary syndromes. So thank you very much.
Thank you, John.